However, I hold no proprietary interest in any of the products I'm going to talk about today. So, as I do not still have this Stellaris, we'll get it next week in Canada. This will talk about evaluating modular products for microincisional cataract surgery with the Bausch + Lomb Millennium system. However, all these products are also available for the Stellaris to optimize microincisional cataract surgery, to increase surgical efficiency and enhance surgical outcomes. And then at the end, to evaluate the insertion of an advanced acrylic microincision IOL through a 1.8 millimeter incision. This was done on 10 consecutive patients scheduled for cataract surgery. Instruments were 19 and 20 gauge irrigating hand pieces, and disposable are available as well. Tapered phaco needles, which I'll talk to you about in a moment, and large irrigating hubs to maximize flow, microcapsulorhexis forceps, and disposable knives. And there is specialized mixed software to provide high vacuum, low flow presets on this machine. With respect to fluidics management strategies, you want to maximize your inflow and minimize your outflow so that you have the most stable chamber throughout the mixed procedure. With dual linear technology, you have simultaneous control of phaco and vacuum, and so this allows you to titrate how much you need to remove the segment that you're removing. If it's a softer nucleus, you'll need less vacuum, and a more dense nucleus, you would want to use more vacuum to remove the nucleus. There is a stable flow needle available with already a constricted internal lumen, as you will see here, and that allows for decrease of your outflow, but still allow you to have the vacuum you need to attract and maintain hold on the piece. And there is also stable chamber tubing, which is cylindrical filter mesh built right into your IA tubing to allow a max vacuum of 500 millimeters of mercury to equal only 50 cc's per minute. And this tubing, unlike others that are available, does not clog. It's coated, and there's an even distribution of resistance with minimization at the end post the cylindrical filter mesh. The advanced acrylic IOL we've heard about already in a few talks today is the Acryos MIL-AO. As a one-piece, unique four-haptic design, and Dr. Murta gave a beautiful description of it, with stable fixation in the bag. 6 millimeter optic diameter, which optimizes posterior edge contact even with the largest capsules. It has a 10-degree posterior angulation, and it uniquely has a 360-degree square edge, so there is no Achilles heel in this, around any of the foot plates in this lens. A PCO rate is very low. Loading is relatively simple with one-handed insertion, which is nice, so then you have control throughout the procedure. The IOL unfolds smoothly, and it centers immediately in the capsular bag. If you try to even push it from side to side, it pops right back into the center. And the IOL rotation into position is unnecessary. It just sits beautifully. It finds its way there. So this is a video of insertion into the capsular bag. I am holding on to the eye through a 1.8 millimeter incision. This is all done under topical anesthetic with the patient providing a little bit of counter pressure. It is a silicone tip. You can see that the lens finds its way into the capsular bag, gentle unfolding, so that even if you had to unfold it in the anterior chamber, it would not hurt any of the iris structures. At the end of the procedure, 1.9 millimeters brought into the wound to show that it fits very well. The wound was not or minimally enlarged by the insertion. And you can see that the lens centers very well. I now have 1 year follow-up on these lenses, and I've done more than 10, but the PCO rate is almost negligible, and they sit very well within the eye. They don't move or rotate. It is an AO platform, which is also an aspheric platform, so visual results are very good. The results of the study show that the small hand pieces are easy to handle. The taper needle facilitated use of microforceps and knives. The instruments were easy to maneuver in the eye for microincisional cataract surgery. The phaco needle itself allowed high vacuum, up to 550 millimeters of mercury, and low flow with efficient fluidics and good chamber stability. The software for the machine's Venturi module raised the pressure up to 300 millimeters of mercury when priming in the anterior mode, and this was beneficial because it minimized the amount of air bubbles that would occur when bringing the phaco needle into the eye. Intraoperatively, the fluid usage was minimal at 75 to 100 cc's per case, and incision size post-lens insertion, as you saw, was between 1.8 and 1.9 millimeters. All corneas were clear at day 1 post-op. Anterior chamber reaction was very minimal. 1 week post-op, the wounds were healthy, no induced astigmatism in my patients. The lenses were well-centered. Uncorrected visual acuity on average was 20/30, and best corrected visual acuity was 20/20. At 6 months post-op, the lenses remained stable and went well-centered, no PCO fibrosis, clear lenses. There are no glistening vacuoles on these lenses, and it is very forgiving. You saw that we pick it up with the forceps to load it in. You do not get forceps marks on these lenses as well. So smooth bimanual phacoemulsification through a small incision with adjuvant mixed instruments and software. Ocular structures are protected and anterior inflammation minimized. The IOL can be implanted through a small incision as small as 1.8, stable in the bag, clear optic over time, excellent visual acuity results. So we're seeing more and more smaller incision IOLs, and so I think we're going to see microincisional cataract surgery finally come of age. Thank you very much.
Thank you, Dr. Mili. Our next speaker will be Dr. Paul, who is going to speak bimanual microphaco in hard cataract. Dr. Paul, please.
Thank you, Mr. Chairman and the distinguished panelists. A very good afternoon to you all. I'll be speaking on bimanual microphacoemulsification versus standard coaxial phacoemulsification in brunescent hard cataracts with sovereign white star eye surgery system. We acknowledge no financial interest in the subject matter of the presentation, and I acknowledge my co-authors for helping me out in this presentation. Coaxial phacoemulsification has been shown to be effective in brunescent hard cataracts with the availability of various advanced chopping techniques, machines with advanced fluidics, machines with power modulation, especially the white star eyes, and now the torsional phaco. Emulsification of brunescent hard cataract has been made very easy. Bimanual microphacoemulsification has also been shown to be effective in early and dense cataracts by various authors, but it has been criticized for its slow approach, inefficiency, and lack of safety in hard cataracts. The purpose of my study was to evaluate the safety, efficacy, and post-operative visual outcome of bimanual microphacoemulsification versus standard coaxial phacoemulsification in brunescent hard cataract with sovereign white star eyes, considering the effective phaco time, post-op endothelial status, and post-op day 1 uncorrected visual acuity. This was a randomized prospective evaluation of 2 groups of 45 eyes each who underwent 20-gauge bimanual and standard, that is 2.8 millimeter coaxial phacoemulsification by the same surgeon. The cataracts were LOCS grade 3 or 4. Exclusion criteria were cataracts of grade 2 or less, any retinal or corneal pathology, previous intraocular surgery, or endothelial cell count below 1800 per square millimeter. In the matrix screen of the machine, we saw the effective phaco time. Post-op endothelial cell loss was seen as a percentage of pre-op density, and uncorrected visual acuity 24 hours post-op. In bimanual phaco, we did 2 1.2 millimeter incisions with a sleeveless phaco tip on the right side, on the left side, and the front open irrigating chopper on the left side. We kept the bottle height to 130 to 140 centimeter. In coaxial phaco, we did a central 2.8 millimeter incision with a sleeved phaco tip, bottle height about 110 centimeter. The surgical process, the technique was the same. There's a central crater followed by a direct chop, a step-by-step chop in situ with lateral separation. In both the procedures, we kept a vacuum around 350 to 400 millimeter mercury, aspiration flow rate 30 to 40 cc per minute, power of 20 to 60% depending on the grade of cataract or the stage of the cataract removal. And the white star eyes with DB and CF was used at the various stages of surgery. We could see the excellent followability with no surge in either of the procedure. That's both coaxial and bimanual. There's the bimanual irrigation aspiration, keeping the irrigating chopper in. The results were plotted, and we found that the effective phaco time in coaxial was 18.6 plus minus 2.7 seconds, whereas in bimanual was 15.3 plus minus 3.2 seconds. There is a reduction by 18%. The endothelial status saw that there was a reduction of endothelial cell count by 8.1% in bimanual, whereas in coaxial it was 8.7%, almost very near to each other. Uncorrected visual acuity 612 or better was found in 73% of cases in bimanual, a bit higher, around 77% in coaxial phaco. Now, if you see the studies of various other authors, the effective phaco time, Olson et al. Has shown a mean effective phaco time of 1.4 seconds and average phaco power of 2.4 plus minus 0.9. These were in grade 2 and grade 3 cataracts. Alio et al. Has showed a mean EPT. There is no difference in the hard cataracts, but the average phaco power was reduced from 19.2 to 5.28. Frischkin et al. Has shown mean EPT of 6.67 seconds with the white star eyes, and Asaf et al. Has shown mean EPT of 4.3 seconds. Our study showed a reduction of EPT by 18%. Endothelial cell count, again, Alio et al. Has showed the coaxial endothelial cell loss in hard cataracts 15.65%, bimanual was 11.37%. Sanyoka et al. Has shown a bimanual of 3 plus minus 14.2 in ordinary hard cataract, and in extreme hard cataract was 9.8. Whereas in our study, it was coaxial was 8.7 and bimanual was 8.1%. It's almost equal. Uncorrected visual acuity on post-op day 1, Olson et al. Was 6.9 or better in 7 out of 18 cases of bimanual hard cataract. Howard Fine et al. Has shown uncorrected visual acuity of 20, 40 or better in 100% cases of bimanual with the star sonic. Our study shows 6-12 or better in 73% of cases in bimanual, whereas 77% of cases in coaxial. So in conclusion, there was a significant reduction of effective phaco time, whereas there was comparable endothelial cell loss and uncorrected visual acuity in bimanual phaco compared to coaxial phaco in brunescent hard cataract. Now, this could be attributed to the better fluidics we found both in the bimanual and coaxial with the sovereign white star eyes with the case setting, but the case 1 and case 2. We got extremely well chamber stability. Bimanual irrigation is one and aspiration other end. This is a closed system with a nuclear fragmentation totally in the bag, less fluid in the eye. There is insignificant leakage with increased followability and a better use of power modulation with the white star eyes. So based on our study, we can say that 20 gauge bimanual microphaco is as efficient as coaxial phaco in brunescent hard cataract with sovereign white star eyes. Thank you for your attention.